Welcome to the StudyNeuro Neuro Lecture Series. In this session, we'll take an in-depth look at brain tumors, one of the most important and rapidly evolving areas in neurology and neurosurgery. Whether you're a medical student, resident, or simply passionate about the neurosciences, this lecture offers a clear, clinically grounded perspective on understanding brain tumors. Before we begin, here's a quick overview of what we'll cover in this session. We'll start by defining brain tumors and reviewing their epidemiology and classification. Next, we'll explore how they cause neurological symptoms, their clinical presentation, and how to localize lesions. We'll then move on to diagnostic imaging, management strategies, and special considerations across different patient groups. Finally, we'll conclude with prognosis, recent advances, and key take-home messages for clinical practice. At the end of this session, you should be able to clearly define and classify brain tumors, understand their pathophysiology, and recognize their common clinical presentations. You should also be able to outline the key diagnostic approaches, summarize management strategies, and appreciate the exciting advances transforming modern neuro-oncology. These objectives will guide our focus throughout the lecture.
Brain tumors arise from abnormal cell proliferation within the brain or its coverings. Most primary CNS tumors originate in the brain itself, with gliomas being the most frequent type. Glioblastoma represents the most aggressive form, while meningiomas are the leading intracranial tumors in adults. Though malignant brain tumors account for only about 2% of all cancers, they cause significant neurological morbidity and mortality. Brain tumors arise from genetic, environmental, and biological factors. Inherited syndromes like Li-Fraumeni, Turcotte, and neurofibromatosis type 1 and 2 increase risk. Environmental exposures include radiation and chemicals such as formaldehyde and vinyl chloride. Age and sex matter. Meningiomas are more common in women, glioblastomas slightly more in men. Immunosuppression and family history can elevate risk. Lifestyle factors including diet, obesity, and smoking are under investigation. Brain tumors are broadly classified as primary or secondary. Primary tumors originate within the brain, its coverings, or supporting structures. Secondary tumors, also called metastatic lesions, arise when cancer cells spread from other organs to the brain. Primary brain tumors originate within the brain, its coverings, or supporting structures, like the meninges and cranial nerves. They may be benign or malignant, yet both can produce serious neurological symptoms due to their location. Glial tumors arise from the brain's supportive cells, astrocytes, oligodendrocytes, and ependymal cells. These are typically intraaxial, occurring within the brain tissue itself. Examples include astrocytomas, oligodendrogliomas, and glioblastomas. Non-glial tumors develop from structures outside the brain parenchyma, such as the meninges, cranial nerves, or pituitary gland. They are usually extraaxial, with common examples including meningiomas, schwannomas, and pituitary adenomas. Recognizing whether a tumor is glial or non-glial guides diagnosis, imaging interpretation, and treatment planning. Secondary or metastatic brain tumors develop when cancer cells spread from another part of the body to the brain. These tumors are often multiple and tend to lodge at the gray-white matter junction, where blood vessels narrow and circulating tumor cells are more likely to become trapped. The most common primary cancers that metastasize to the brain include lung, breast, melanoma, and kidney cancers, though other malignancies can also spread. Metastatic brain tumors are a major concern because they are the most frequent intracranial tumors in adults. Understanding their origin and pattern is crucial for planning treatment and improving outcomes. The grading of brain tumors provides crucial information about their biological behavior and prognosis. Grading is determined by key microscopic features: cellular proliferation, vascular changes, and necrosis. The World Health Organization, or WHO, first introduced its classification system in 1979. The latest, fifth edition, released in 2021, now incorporates molecular markers alongside traditional histopathology. Earlier editions used Roman numerals, grades I to IV, but the 2021 update replaced these with Arabic numerals 1 through 4 for clarity and consistency. The WHO grading system aligns closely with the St. Anne Mayo criteria, which are also based on histological features such as atypia, mitosis, vascular proliferation, and necrosis. The WHO grading system classifies brain tumors from grade 1 to 4, reflecting their biological behavior and prognosis. Low-grade tumors, grades 1 and 2, grow slowly and are less aggressive, but may recur at a higher grade over time. High-grade tumors, grades 3 and 4, are malignant, fast-growing, and associated with poor outcomes. Grade 1 tumors, such as pilocytic astrocytoma, are usually benign and curable with surgery. Grade 2 tumors are infiltrative but slow-growing. Grade 3 tumors are anaplastic and more aggressive. Grade 4, represented by glioblastoma multiforme, is the most malignant and rapidly progressive. The St. Anne Mayo system grades tumor using 4 key microscopic features: nuclear atypia, mitosis, endothelial proliferation, and necrosis. Grade 1 shows none of these features. Grade 2 meets one criterion, usually nuclear atypia. Grade 3 shows 2, typically atypia and mitosis. Grade 4 meets 3 or all 4 features, indicating a highly aggressive tumor. Tumors produce neurologic symptoms through mass effect, invasion, and secondary changes. As the lesion expands, intracranial pressure rises, leading to headache, vomiting, and papilledema. Local infiltration causes focal neurological deficits, while compression of CSF pathways may lead to obstructive hydrocephalus. Peritumoral vasogenic edema, mediated by vascular endothelial growth factor, further amplifies mass effect and clinical symptoms. The presentation of a brain tumor depends on its location, size, and rate of growth. General features of raised intracranial pressure include headache, often worse in the morning, vomiting, and papilledema. Seizures are particularly common in supratentorial tumors. Focal signs help localize lesions. For example, hemiparesis suggests motor cortex involvement, while aphasia implies dominant hemisphere lesions. Frontal lobe tumors may cause disinhibition and personality change. Localizing a brain tumor clinically is a key step in neurological assessment. Each region of the brain produces characteristic signs when affected. Frontal lobe tumors may cause personality change or motor weakness. Temporal lobe lesions often present with seizures and memory impairment. Parietal lobe involvement leads to sensory loss or spatial neglect. Occipital lobe tumors typically cause visual field defects. Cerebellar lesions produce ataxia and poor coordination, while brainstem tumors result in cranial nerve palsies and long-tract motor or sensory signs. Understanding these patterns helps narrow down the tumor location even before imaging is performed. Diagnosis begins with neuroimaging. CT is vital in emergencies and for detecting calcification or hemorrhage. MRI is the gold standard for tumor characterization and surgical planning. Advanced tools, MR spectroscopy for metabolism, diffusion tensor imaging for white matter mapping, and perfusion MRI for assessing tumor vascularity, grade, and treatment response, enhance precision. Final confirmation relies on histopathology and molecular markers like IDH mutation, MGMT methylation, and 1p19q co-deletion. Management of brain tumors is fundamentally multidisciplinary. Whenever feasible, surgical resection is the first step, aiming for maximal safe removal. Radiotherapy and chemotherapy follow, depending on histology and grade. For example, temozolomide with radiotherapy for glioblastoma. Corticosteroids, such as dexamethasone, alleviate peritumoral edema, while antiepileptics prevent seizure recurrence. All cases benefit from tumor board discussions, integrating neurosurgeons, neuro-oncologists, radiologists, and pathologists. In children, posterior fossa tumors, such as medulloblastoma and epidemioma, predominate. In adults, gliomas, meningiomas, and metastases are more frequent. Emergency presentations include acute hydrocephalus or herniation syndromes, demanding urgent neurosurgical intervention. Long-term care must address functional recovery, cognitive rehabilitation, and palliative support where cure is not achievable. Prognosis depends on histologic grade, molecular profile, and the extent of resection. Recent innovations, including intraoperative MRI, fluorescence-guided resection with 5-aminolevulinic acid, and neuronavigation, enhance precision and safety. Future directions include immunotherapy, molecular targeted drugs, and artificial intelligence for image analysis and treatment prediction. To summarize, brain tumors are diverse in origin and behavior, but share common pathophysiological pathways. A systematic approach, clinical suspicion, accurate imaging, histological confirmation, and tailored therapy forms the foundation of effective management. Modern neuro-oncology continues to evolve, emphasizing precision, safety, and patient-centered outcomes.
In summary, brain tumors, though relatively rare, carry significant implications for neurological health and patient quality of life. Effective care requires accuracy at every step, from clinical evaluation and advanced imaging to molecular profiling and multidisciplinary management. As innovations in surgery, radiotherapies, and targeted therapies continue to advance, the future of neuro-oncology is becoming increasingly precise and hopeful. You've been watching the StudyNeuro Neuro Lecture Series, making neuroscience clear, clinical, and connected. Join our growing community of learners. Don't forget to like, comment, share, and subscribe to youtube.com/StudyNeuro for weekly videos on neuroscience, neurosurgery, and clinical neuropractice.